My approach to HRD and BRCA testing is fluid in the sense that things are changing very rapidly, I think, that many people are aware of. So a number of companies developing new tests to try to identify homologous recombination deficiency. Currently, I do use the MyChoice data because it was embedded in these clinical trials, and I find that is helpful in terms of validity and in terms of predictive value. One always has to look at the presentation by Dr. Swisher at SGO that questioned in the Velia study the predictive value of HRD. Nonetheless, that was with a different cut point at 33 instead of the normal 42 that's used in that was used in Prima and was used in Palo 1. So for me, I do use MyChoice in terms of HRD testing. I think the really important thing for everyone to remember, though, is that we must get BRCA status on these patients. And I think that's one thing that sort of gets missed in the complexity and the ever-changing dynamics of, quote, testing in this arena. Why is it so important? First of all, it's obviously very prognostic. It's incredibly important to know whether the patient has a BRCA mutation because we know the power that the PARP inhibitors have in that particular patient population for sure. HRD, definitely. It's great to know that. But BRCA is a necessity. And don't forget the cascade testing. So testing family members is so important in this setting because not only are you going to help give the best therapy to your patient, you're potentially going to save other lives in her family. So BRCA testing must be remembered to be done even if you don't get HRD testing.